I'd like to thank SAGES for giving us the opportunity to present our research today. We have nothing to disclose. Patients who are diagnosed with gastroesophageal reflux disease are often started empirically on proton pump inhibitor medications without any objective confirmation that they actually have reflux. Patients with refractory symptoms or poorly controlled symptoms on their medication commonly undergo impedance-pH testing while on their medications. This is done for two reasons. It's done first to confirm that the medication is actually supplying adequate acid suppression, and secondly, it's done to evaluate for the total number of weak or non-acid reflux events that might be contributing to their symptoms. However, there are concerns about impedance testing. If you look in the literature, normals for impedance testing on medications are not well established. In addition, the number of reflux events has the highest standard deviation and the lower sensitivity and specificity for detecting reflux in the Demeester score compared to all other parameters. When speaking about anti-reflux surgery, we know that the outcome of anti-reflux surgery is linked with the confirmation that the patient actually has reflux disease. We know that greater than 90% of patients who have typical symptoms, a good response to PPI medications, and have a positive pH test off their medications will have a successful result. However, the relationship between an abnormal impedance test on medications based on their total number of reflux events and increased esophageal acid exposure based on pH testing off medications is unclear. We do know that a Bravo 48-hour pH testing has a higher sensitivity in detecting reflux than catheter-based 24-hour pH studies. So our aim in this study was to compare the results of impedance testing on medications to Bravo pH testing off medications in patients being considered for anti-reflux surgery. And we're doing this to determine whether an impedance test on medications can be reliable in selecting patients for anti-reflux surgery with the hope that they would have a high likelihood of success. So our study's design consisted of a retrospective review of about 282 patients who we placed Bravos and did testing off their medications. We looked retrospectively and found that 50 of these patients actually had a prior pH impedance study on their medications. One of these patients was excluded, and that's because the patient actually had a positive pH test on their medications in the impedance-pH test, and so we had a total study cohort of about 49 patients. The methods to our study was that patients who underwent an impedance-pH test on their medications were on their PPI therapy for at least 1 month. We defined the total abnormal impedance reflux events as defined as greater than or equal to 48 total reflux events. For the Bravo testing off their medications, PPIs were discontinued for 7 days prior to Bravo placement, and an abnormal Bravo pH was defined as a Demeester score of 14.7 on either day. So what did we find? We found that in the 49 patients who had an impedance-pH test on medications, that 51% of these patients had an abnormal impedance. We then looked at their Bravo, and of the 49 patients who had a Bravo pH test off their PPI, we found increased esophageal acid exposure, or an abnormal pH, in about 76% of these patients. So when we then looked at how this correlates with patients who have an abnormal impedance and a normal impedance to their off-medication Bravo, we found that patients with an abnormal impedance, the graph here on the right, basically had 84% of those patients had an abnormal Demeester score. So if you have an abnormal impedance on medications, 84% had an abnormal Demeester score off medications. Interesting though, if you look at the normal impedance on medications, patients who had normal impedance, 2/3 of those patients actually had an abnormal Demeester score, whereas 1/3 of those patients had a normal Demeester score, indicating that they didn't have reflux disease. So we looked at the correlation to try to determine the sensitivity, the specificity, the positive predictive value and the negative predictive value of using an abnormal impedance on medications to diagnose pathologic reflux like we do with the gold standard of an off-medication study. And we found that the sensitivity was 57%, the specificity was 67%, our positive predictive value was 84%, but our negative predictive value was 33.3%. So in trying to see if this is a decent test, a on-medication impedance-pH test in diagnosing pathologic reflux disease in patients being considered for anti-reflux surgery, we generated a receiver operating characteristic curve. And as you can see here on the table on the right, when generating this curve, it will determine whether a test is great, good, fair, poor, or bad at diagnosing a specific thing based on its characteristic. Well, our curve that we generated is here, a receiver operating characteristic curve, is 0.71, indicating that for diagnosing pathologic reflux disease, it's only a fair test. So to determine whether there are anything else contributing to these differences that we're finding between these groups, what we did is we looked at all the patients who had a previously abnormal impedance and all the patients who had a normal impedance and tried to compare them. The first thing that we saw was that there is an actual difference in age. It is statistically significant. And the other thing, which is to be expected because we're comparing abnormal and normal impedance groups, there's a difference in median reflux events. But what we didn't find a statistically significant difference for to account for this correlation was the percentage of twice daily PPI use, the presence of a hiatal hernia greater than 1 centimeter, Barrett's esophagus, esophagitis, esophageal strictures. There was no significant differences between these two groups to indicate, what we're finding in the study. So there's two important conclusions from our research that I think we can make. The first is that when we're using impedance-pH testing on medications, it does not determine reflux disease reliably enough to offer patients an anti-reflux procedure, because 16% of those patients who had an abnormal impedance did not have increased esophageal acid exposure. Second conclusion that we can make is we believe that the best initial test in patients who have a poor response or have refractory symptoms to PPI therapy should be a pH test off medication, not an impedance pH test on medications. And this is because abnormal impedance is not sufficient to select patients for surgery, and even if you have a normal impedance, it does not confirm the presence of reflux disease or explain persistent symptoms. Because in our data, it shows that 33% of patients had normal Demeester score off medications and a normal impedance on medications, indicating that they had no actual reflux disease. Thank you, and I'll take any questions.
Thank you. That was a very well-designed study. The only problem I see in your study is that, to start, you're assuming that the Bravo, which is a great study, and I do that every single day, is the gold standard, but it's not. I think it will make more sense in your study if you compare the impedance-pH study on medication to impedance-pH study off medication, and then look for the positive predictive value and negative predictive value instead of comparing impedance to Bravo, because truly we don't know how Bravo compares to impedance.
Right, that's what we're trying to figure out a little bit, but as mentioned previously, the reason we chose Bravo is because it has a higher sensitivity of detecting reflux disease than the ambulatory pH off medication and catheter-based. So by having that increased sensitivity, we thought we'd have a better idea of actually diagnosing pathologic reflux disease because of that increased sensitivity and pickup.
Well, it's true and it's not. It's debatable because it depends on how you're doing the Bravo, how long you're doing the Bravo for. There's some technical issues with the Bravo, and there's also some technical issues with the impedance. So some studies have shown that the Bravo has a higher sensitivity, but many experts would say impedance and pH study is still the gold standard.
Okay.
And I'm saying that, and I don't use impedance. I use Bravo, but you have to be honest with yourself. Bravo is not truly the gold standard.
Shamit Metal, Phoenix again. A few points. I agree with one statement that made that the first test after a person who does not respond to PPI should be a pH testing off therapy. However, so I don't know how you came to this conclusion, but could this be explained just by day-to-day variability in the time the people have reflux? You said you used a Bravo test for 48 hours. Either day was used. You would probably notice that people don't have positive pH on both days. So you did similarly a pH study or an impedance study on the day they were not having reflux. So that could explain some of your findings. Secondly, you used the number of reflux episodes, and on the Bravo, you used the Demeester score, which is a combination of the reflux episodes and the duration of reflux episodes. So you're comparing, I think, apples and cherries, and except for it just doesn't add up. You could have looked at the number of reflux episodes in Bravo also. Because what if you have a prolonged reflux episode that lasts for 5 minutes? That has a higher value to give you a higher Demeester score, but on impedance, it'll be just one episode. Have you thought about that as a possible reason of these findings? So one, day-to-day variability in reflux. Two, the basis of which you're calculating that abnormal Demeester score is 14.7 and comparing that to a number of MIE episodes. And if you look at the abnormal number of MIE included episodes is actually 74 and not 47. You use 47 because that's abnormal number of acid-based episodes rather than the total impedance episodes. Mm-hmm. And so I was wondering, what are your thoughts about those, and would that explain the discrepancy? And
so I think that although reflux is a component of the Demeester score, as previously said, it has the lowest sensitivity and specificity in creating that score. We know that we diagnose pathologic reflux disease with an off-medication test. So by looking at the impedance, what we're trying to see is that we often get patients who actually are referred to us for anti-reflux surgery without even having a confirmatory test off medications. And so I guess, and I think I'm answering your question in that, could the impedance events play a role in what we're finding? Potentially. But in terms of the day-to-day variability, that's also possible, and that's why we chose the Bravo, because it was over a longer period of time to make sure we got an abnormal Demeester score.
Could that just be the reason that it is more sensitive, because it's over a longer time? Let's not go back and forth. Mm-hmm. And the last thing is the gold standard was based on a catheter-based pH of 14.7, not a Bravo. Bravo is an extension, and it is more sensitive, potentially because it causes less hindrance to their lifestyle, maybe normal diet, and two, it is over 2 days. Mm-hmm. So I think the answer would be an MIE pH or just a regular pH off therapy.
Okay.
Compare the two.
Thank you very much.